Welcome, everyone. This will be the fifth session of our Opioid Prescribing and Overdose Prevention Learning Collaborative. I'm John Glover, a Quality Improvement Advisor for Superior Health Quality Alliance, or Superior Health. Superior Health provides support for healthcare organizations in Minnesota, Wisconsin, and Michigan under a federal grant from the Centers for Medicare and Medicaid Services. Today's session will focus on recommendations 8 through 11 from the CDC's updated 2022 Clinical Practice Guideline for Prescribing Opioids for Pain, which addresses assessing risks and potential harms of opioid use. Following today's presentation, there will be one more 30-minute session during which we will discuss the CDC's recommendation number 12 having to do with providing treatment for opioid use disorder. Superior Health has also developed an opioid prescribing and overdose prevention toolkit to complement these sessions, and we will be putting a link to that in the chat following this session. Yvonne Burston, who is also a Quality Improvement Advisor at Superior Health, will be helping us with questions and comments in our chat today, as well as providing links to various materials throughout the session. Before we get started, please add your name, organization, and role into the chat. And if you have any others with you, please include their names as well. A few housekeeping items. We will have one polling question at the beginning of today's session and one at the end of the session. We will also be putting a link to a brief survey for this session in the chat, and we'll give you a few minutes to fill this out. During the session, if you have a question you would like to ask verbally instead of in the chat, please raise your hand and we'll be happy to take you off mute. Dr. Dibble is our speaker today. Dr. Dibble, take it away.
Welcome, and thank you so much, John. My name is Rachel Dibble, and we will be discussing today assessing risks and potential harms of opioid use. This learning collaborative, as John said, is recommendations 8 through 11 from the CDC. It is a collaborative that has been built upon each other, so if you would like to go back and listen to the prior sessions, please do. So that you could get the whole series, and there will be 6 in total. So our learning objectives today, so participants will be able to, after the session, determine with the patient a management plan to mitigate risk of opioid-related harm, assess for potential risks of opioid-induced overdose using patient history and prescription drug monitoring program, or PDMP, as we know, understand the rationale for toxicology screening, and evaluate the risk of prescribing benzodiazepines and other central nervous system depressants concurrently with opioids. Next slide. So we'll start off with a polling question just to get a feel of where everyone is and their thoughts about this question, and then we'll review it at the end. But if you could take a minute to answer, which medication or medications might cause central nervous system depression when prescribed concurrently with opioids? Benzodiazepines, gabapentin, sleep aids, all of the above, or none of the above? So recommendation number 8. And what I did was I actually gleaned the text from the CDC guideline because I would like you to actually see the guideline, and then we'll discuss it a little bit more in detail. So the actual recommendation number 8, so before starting and periodically during continuation of opioid therapy, clinicians should evaluate risks for opioid-related harms and discuss risk with patient. Clinicians should work with patient to incorporate into the management plan strategies to mitigate, including offering naloxone. So in essence, what this really looks like, and the focus is patient-centered care. So when you are prescribing short-term or long-term opioid therapy for acute, subacute, or chronic pain, the idea of discussing with your patient, for example, occupation would be a great question to ask, of what they do for a living. What does your day look like? How much do you have to drive? To incorporate a plan, particularly with timing of taking opioids and what is safe to mitigate any risks of taking opioids. Also including offering naloxone. For myself personally as a prescriber, that's just my best practice. I always offer naloxone and prescribe it to ensure that the patient has it and train them on how to use it appropriately. Next slide, please. So implementation considerations of how to implement recommendation number 8. One of the first point is to really assess your patient about their drug and alcohol use with validated tools, or consult with, potentially, if they give you access to talking to their therapist, counselor, psychologist, social worker, to screen and assess for mental health and substance use disorders. And that could be potentially something that has been missed in the diagnosis in the past, and or as of present today, that there is a mental health issue. And sometimes these are missed. We know with substance or mental health issues, sometimes there are substance abuse issues that go along with this. It is imperative. It is not a punitive conversation. It is, tell me about your life. Tell me about you. Tell me about your day, to really dig into understanding what their life looks like. And then if we throw on opioids, what that will do. Will it help or will it hurt? When considering initiating long-term opioid therapy, ensure that treatment for depression, in particular depression and other mental health conditions, is optimized. I highlight depression because depression often, from a patient's perspective, could be classified as pain. And it does feel like physical pain for some patients. But then when we get down to it's really depression, then it's not a physical pain. I've seen this in practice often. Once I get my patients talking, really using your counseling hat, if you will, open-ended questions. You're really trying to dig of what this patient's real-time life looks like. So when possible, avoid prescribing opioids to patients with moderate or severe sleep-disordered breathing to minimize risk of respiratory depression. This is particularly important for your COPDers. Your COPDers often are prescribed even morphine if they get into a respiratory distress situation, and benzos long-term for their anxiety because of their shortness of breath. So if they are on that and then we throw on an opioid, particularly long-term, that's not managed properly, we've got two drugs that can depress your respiratory system. And so these are things that we really need to look at with our pulmonary chronic diseases. We need to use caution and increase monitoring to minimize risk of opioid prescribed for patients with renal or hepatic insufficiency, for patients aged 65 or older. What this really means is we need to look at our creatinines, we need to look at our specific gravities, and we need to look at our liver function, our ACT, ALTs, because our oxycodones or hydrocodones, those medications go through the liver. And then for some of your other opioids, the filtration goes through the kidneys. So it's really important to look at these labs prior to prescribing. Or if you're not a prescriber and you have access to the chart, you could take a quick glance to ensure this is safe. Next slide, please. For patients with jobs, again, that involve potential hazardous tasks, these are patients to really look at, and all of the other risk factors that can negatively affect them insofar as sleep, cognition, balance, coordination. Clinicians should assess patients' ability to safely perform the potential hazardous tasks. This is super, super important, particularly for the folks who get harmed on the job and they go back to work. I think of particularly construction workers with my experience. Clinicians should use the PD&P data and toxicology screening as appropriate to assess for concurrent substance use that might place patients at higher risk for opioid use disorder and overdose. That is self-explanatory, but in our next, or rather two recommendations forward, I get deeper into this. It is an extraordinary, important point, a high yield point for providers. Next slide, please. Recommendation number 9, when we prescribe or initiate opioid therapy for acute, subacute, or chronic and periodic pain, clinicians should review the patient's history, again, of controlled substances through the PDMP data to determine whether the patient is receiving opioid dosages or combinations that put the patient in high risk for overdose. Next slide, please. So when we look at our PDMP data before we prescribe, as we know, they are state specific. So for example, I live in Tennessee. I might not have access to that patient who came to Tennessee for cancer treatment who was prescribed opioids in Kentucky. Also, so right there we see the gap in care. This is why the open-ended questions, the how many physicians are you seeing, who prescribes what. I would often have my patients bring in their bags of medications, all of them. And you would be very surprised. We have to think of it from a patient's perspective. They are sick, they are on opioids, and their cognition is probably not as acute or sharp as it used to be, right? So when we think about that patient, they may not even know or remember that a benzo is a scheduled medication. It is a high-risk medication, obviously the opioids, but there are other things out there that are as well. So in this, the attitude of going potentially to your PDMP and seeing results that the patient didn't tell you, this is not a punitive exercise. This is 100% about keeping a patient safe. They could be taking medication that they did not know would come up on a PDMP. They didn't know to tell you. Maybe they brought it and you educated on, hey, this is an opioid. Did you know this? This is high risk. You're going to have a fall risk with this. You're going to have, potentially overdose with this. And then that's how we open up the discussion. We destigmatize this. We make it okay. We make it to where we want to help our patients and keep them safe. So at a minimum, during long-term opioid therapy, the PDMP data before we initiate opioid prescriptions, and then every 3 months or more frequently. My personal practice was monthly. Use specific PDMP information about medications prescribed to patients in the context of other clinical information, including patient's history, physical findings, and other related testing. Do not fire or dismiss a patient on the basis of this information. I've had it also to where it wasn't correct. And I pick up the phone and I call all the pharmacies that the patient has touched to understand what they're on, why are they on it, when were they prescribed the medication, and then that guides me into what I'm going to do. Furthermore, I've also had case scenarios where the patient said, I've been taking this for 10 years. I don't know why. I call the doctor. Do we still need to continue this? I've got another medication that could also cover this, and the benefit would be better than the risk than these 2 medications. So it's really being at the helm of when you're dealing with these medications that can kill people. It is our responsibility to look at this information, to synthesize it, understand it. It is a group effort, not one provider or one clinician can mitigate the risk of potential overdose and cross prescribing. Next slide, please. Recommendation number 10 rather. So when prescribing opioids for subacute chronic pain, clinicians should consider the benefits and risks of toxicology testing to assess for prescribed medications as well as other prescribed and non-prescribed controlled substances. Next slide, please. So for implementation considerations, this again is the overarching theme here is to test toxicology and to ensure that your patient doesn't feel like they've done something bad. That's what we don't want. We don't want them to feel like we won't prescribe. We just have to understand the circumstance. So toxicology testing should not be used in a punitive manner, but should be used in the context of other clinical information to inform and improve patient care. Do not, again, dismiss patients on toxicology results. This is a great window to, if there is a problem, mental health problem, dependence, addiction, that's a wonderful window or door opening to start that conversation to potentially get them help. And that could be all that that patient needed, someone who cared, someone who noticed, someone who talked to them. So before starting opioids and periodically, at least annually during opioid therapy, consider the benefits and risks of toxicology testing to assess for prescribed opioids and other prescription, non-prescriptive controlled substances. The idea here is that we don't want to inadvertently have people overdose. When I spoke about the kidneys and the liver, so if we have kidney liver problems, we may be toxic and not even know it. So again, these are the things that should metabolize in our system in 2 or 3 days. Maybe they have built up because we are not filtering it. Again, we know that from a tox screen. So predicting risk is challenging, and available tools do not allow clinicians to reliably identify patients who are at low risk for substance use or abuse or disorders. So again, we need to consider the tox screenings. The other thing I want to mention is that there are things such as false negatives and false positives. And when this happens, and it does happen, and they could be in a bucket, for example, they're taking alprazolam, clonazepam, or lorazepam. So that's in the benzo bucket. But they could get a false negative for that because they are synthetic drugs, for example. But you might be on sertraline and have a false positive. So that's when our critical thinking has to happen. What are they on? Why am I getting this? And open the discussion of safely prescribing. Next slide, please. Explain to patients that toxicology testings, again, will not dismiss. We just want to keep our patients safe and know what's happening, mitigate their pain, address mental health issues if needed. Talk with the patients about expected results. What are you expecting? What are your goals? Again, that leads you into guiding them and what you will do. Limited toxicology screening can be performed with a relatively inexpensive presumptive immunoassay panel, and that's your urine screen. And discuss unexpected results with your patient in a non-judgmental manner. So avoid using the potentially stigmatizing language as avoid describing a specimen as testing as, oh, your urine is dirty. That is not productive for your patient. It's, oh, I have these results, let's discuss them. And again, you will find out a lot of information about your patient. Next slide, please. Recommendation number 11, last recommendation for today. Use particular caution when prescribing opioid pain medication and benzos concurrently. Consider whether the benefits outweigh the risks of concurrent prescribing of opioids and other central nervous system depressants. Next slide, please. Implementation considerations. So in some circumstances, it might be appropriate to prescribe the opioids to a patient who is also prescribed benzos. So again, that patient is particularly the COPD patient. They've been on stable benzos for 10 years, 15 years. They've been on low-dose opioid. It works for them. They're fine. But we start messing with their pain regimen because their pain is increased. We need to go back and look at that benzo and ensure we're not harming them. But they need it so that they don't panic when they can't breathe. So it's that circle, and we have to be mindful of that. Buprenorphine or methadone for opioid use disorder should not be withheld from patients taking benzos and other medications. So again, that should be available to your patients. Consider involving pharmacists. Pharmacists, I have found, are my best friends. They will help you navigate some of these medications and side effects, contraindications, etc. And in specific situations, benzos or benzodiazepines can be beneficial, and stopping benzodiazepines can be destabilizing. Very true statement. With benzos, you got to taper the benzos because if you stop them abruptly, you'll harm your patient. Next slide, please. Summary and takeaways from recommendations 8 through 11. I really want to highlight naloxone, high yield takeaway when prescribing opioids. This can save people's lives. Check the PDMP when prescribing opioids. Do not use this as a punitive tool, rather look at it as an informative tool. Respiratory depression medications, really big concept to be mindful of. Tox screening, again, it can do a lot of good, and we can be the voice out there as healthcare providers to destigmatize opioid use when it's used appropriately. Assess for history of overdose and or mental health conditions. Again, another opportunity to save a life. So let's prescribe responsibly and mindfully, non-judgmentally, and prescribe safely. Next slide, please. So polling question. Let's try it again here. So having attended this session, which medication would you say now might cause central nervous system depression concurrently prescribed with opioids? So you have your benzos, gabapentins, sleep aids, all the above or none of the above? And Yvonne, I'm not seeing the answers, so you're going to have to let me know.
Okay. We're still waiting on a few to answer.
Okay.
So I'm just going to go ahead and end it. It looks like most of your answers are all of the above, and I'll share it and see if you all can see it. Can you see it?
Yes, that is great. All of the above, and it is all of the above. Again, your sleep aids, think about your ambience. That's what I wanted to say about the results there. That will cause central nervous system depression with opioids as well. So be mindful of those. Next slide, please. And does anyone have any questions? Please ask away. We're here to help. We want to support and you and your patients and your practice.
Rachel, this is John. I really appreciated your comment about how you can use either the PDMP or especially toxicology screening to kind of assess how the liver and kidneys are functioning, which is a great way to destigmatize things, right? This is not just to see if it's there or not, but to see how much is there and whether or not, your body's processing these medications the way we're expecting, right?
That's exactly right. And a lot of overdoses happen because just our kidneys aren't working correctly. I mean, so it's really a safety measure. Okay. If you do have any questions, we do have a contact that please feel free to contact us. I would highly recommend accessing the opioid prescribing and overdose prevention toolkit that has been put together with the recommendations and the implementation considerations with wonderful resources. Let's change this, and it starts with us. And take a look at the toolkit. Next slide.
Right. So thanks so much, Rachel. This is Rachel's contact information. If you have questions or want to reach out to her to clarify things that maybe we've talked about during the session, feel free to do that. And here's the date for the upcoming session on the CDC's recommended prescribing practices. If you haven't already, please register by clicking on the link in the chat. Yvonne will put that link for you in the chat Please note that our next session is just 2 weeks from today due to the Thanksgiving holiday in November. And we want to thank Dr. Dibble for a great presentation today. Additionally, on this slide, you'll see Superior Health's Connect link. If you haven't joined already, please do. Connect is used as a platform to share information and continue conversations on a variety of healthcare topics. This concludes our presentation today. You'll also see a link to today's slides in the chat. We wish you a good day. Thank you for joining us, and we'll see you next time.
And please take some time and answer the survey that's in the chat to let us know how we're doing.
Please do, and it helps us so much going forward with ideas and thoughts about things that you need. Again, we're here to support you. So please take just a second. We've honed them down to where it should just take a second to do these, and they're super helpful. So thank you so much.
Well, hopefully you're taking a second to complete our survey for us. We really appreciate that. We look forward to seeing you in our next session in 2 weeks.